I'm Dr. Fakir Averi, and this is sexually transmitted infections in adults. Many infections are associated with sexual transmission. Now, these were traditionally termed sexually transmitted diseases or STDs, and currently they are termed sexually transmitted infections or STIs. Now, by calling them infections rather than diseases, we can reduce the stigma associated with STDs and place these infections within the context of a larger sexual health framework. And not all of these STIs will manifest as an actual disease. Now, since 2000, rates of STIs have continued to rise. For example, chlamydia cases have doubled during that time, gonorrhea has increased 40%, and primary and secondary syphilis cases have soared fivefold. And nearly half of STIs are acquired by teens and young adults between age of 15 to 24 years old. The first STI that we'll discuss belongs to the human herpes viruses family. So these are the herpes viruses that contain double-stranded DNA. They're surrounded by a nucleocapsid, which is wrapped inside a tegumen consisting of several viral and cellular proteins, which are in turn surrounded by an envelope which has viral glycoproteins. Now, human herpes viruses are divided to three subfamilies, so the alpha, beta, and gamma. Within the alpha family, we have herpes simplex virus 1 and 2, which, essentially there are 8 of these human herpes viruses that infect humans. So these are dubbed HHV 1, 2, 3, 4, 5, 6, 7, and 8. So the first one, HHV1, is specifically herpes simplex virus 1, and along with HSV1 and HSV2, these are viruses that essentially lead to latency. So once somebody is infected, they will reside on sensory and cranial nerve ganglia, and they will have a period of latency, and they will periodically get reactivated. And the third member of the alpha family is a varicella zoster virus. So, sometimes you will hear the term herpes zoster infection. So it's important to distinguish that from the HSV-based herpes infections. Now, when you look at the seroprevalence among adults in the US, you can see that about more than half of people in the US are actually infected with HSV1, which in general is considered the less severe of the two. And this doesn't necessarily mean that it's is a sexual or genital infection, because HSV1 can also reside outside of the genital area. Whereas, far fewer people, so about up to a quarter of the US adults have HSV2. Now, HSV2 is more likely to cause genital herpes, but regardless, both of these can, either cause infection in the face, orofacial area, or in the genital area. And once, they are there, they will have latency. Other herpes viruses that are clinically important include cytomegalovirus or CMV, which belongs to the beta, and EBV, which belongs to the gamma. However, these are not necessarily sexually transmitted infections, but they do have a role in immunocompromised patients. For this topic, we will focus on genital herpes that's caused by herpes simplex virus. Now, other infections that we will talk about in this topic that are non-viral are chlamydia, gonorrhea, and syphilis. Chlamydia specifically is caused by a typical bacterium called Chlamydia trachomatis. This is an obligate intracellular bacterium, so essentially has to go inside the cells of the host in order to replicate, which, if you think about it, that makes it difficult to culture in the lab, because they have to be inside the cell, so you cannot just grow them on a plate. And there are a lot of similarities between chlamydia and gonorrhea as far as manifestation. Now, essentially, they infect the epithelium cells, and that could be, in the eye, in the genital urinary tract, or in the rectal area. But essentially, they attack the epithelium. So gonorrhea, in comparison, is caused by Neisseria gonorrhoeae, which is a gram-negative cocci. And similar, a lot of similarities between these two as far as manifestations, because they do infect the epithelium cell, but they are vastly different organisms, and treatments are different, more or less. And gonorrhea in general is considered more severe, and is more likely to cause disseminated gonococcal infection. And disseminated essentially means that everywhere in the body. And resistance is also an issue with gonorrhea, which we'll discuss briefly. Syphilis, which is caused by Treponema pallidum, which is a gram-negative spirochete. So essentially, this kind of looks like a spring, so to speak, the shape of it. And syphilis is a very severe infection in the sense that but first of all, it has a multi-stage infection. So it goes from very mild infection to essentially life-threatening infection over a period of time. So it essentially disseminates early during the course of infection and invades the central nervous system. This can happen at any time during the course of the infection. Now, when we look at resistant patterns, in regards to the report from CDC that was published in 2019, you can see that the drug-resistant Neisseria gonorrhea is actually an urgent threat level. And to put it in perspective, there are only 5 organisms that get the urgent threat level from CDC. That includes carbapenem-resistant Acinetobacter, Candida auris, Clostridioides difficile, carbapenem-resistant Enterobacterales, and drug-resistant Neisseria gonorrhoeae. So this is, urgent because, when you get this type of drug resistant, we don't have a lot of treatment options. And you can see on this small chart down here that as time goes on, the rate of resistance continues to go up to the level that, over a period of time, we have been essentially losing the treatments that we had as an option. Now, the first learning objective is describe the pharmacokinetics and pharmacodynamic properties of anti-infective agents used for the treatment of genital herpes, gonorrhea, chlamydia, and syphilis. So when it comes to antiviral agents for the management of herpes viruses, the 3 most important ones include acyclovir, valacyclovir, and famciclovir. And we also have some topical options that, they're not necessarily, used for genital herpes, but, when you consider, for example, orofacial, for example, Abreva is something that's available over the counter when people have facial manifestations of HSV, and those are topical, so they're listed here. But I want to focus on the 3 that are used systemically for management of patients with genital herpes. So acyclovir, which these are essentially analogs of nucleosides. So acyclovir is a acyclic guanine analog, and because it looks like guanine, it essentially inhibits viral DNA synthesis. So herpes viruses are DNA viruses. And acyclovir is available as IV, as PO, and as topical. Now, it's important that this is pretty much the IV drug of, in case of severe infections, this is the IV drug to go to. But in general, oral options are the mainstay of treatment. Now, the problem with acyclovir is twofold. One is that, the oral bioavailability is very low. So it's about 10 to 30%. And that's why we have valacyclovir. So essentially, this is a valine ester of the acyclovir. And that valine essentially improves bioavailability. So it actually increases up not to 100%, but essentially, up to 70% bioavailability. So, that essentially improves that. But other than that, the 2 drugs are pretty similar as far as adverse effects. And, of course, valacyclovir is not available as IV. Now, when you look at the adverse effects, essentially GI effects, so nausea, diarrhea, but also rash, headache, and rarely neurotoxicity. So, and this would be in the case of, because these are renally clear. So if somebody has renal dysfunction, if they're not renally adjusted, or, just in case of overdose, patients are likely to have neurotoxicity, and this neurotoxicity could include seizures. So typically confusion, hallucination, but could include seizures. And with the IV formulation of acyclovir specifically, it's also a nephrotoxic agent. So because with the IV we'll have high doses, and I emphasize IV because if you think about it, the PO version is only about 10 to 30% absorbed, so you're less likely to get these severe rare adverse effects. But with the IV, which you have 100% availability, you're going to get high doses, and so it's one of the nephrotoxic agents. So specifically it can form crystallines, so it can cause obstruction, but also it can cause interstitial nephritis. So that's one of the types of AKI, and so that's something that you don't see with valacyclovir. And then famciclovir also is a prodrug of penciclovir. So penciclovir is only available as topical, so I'm not really going to talk about it, but essentially famciclovir is a prodrug of penciclovir that improves bioavailability, but mechanism of action is the same. So essentially all of these 4 drugs are analogs of guanine, which inhibits viral DNA synthesis. And here's how it works. So essentially for DNA synthesis, you need nucleic acids. So when you have your 4 nucleic acids, right? So you have thymine, adenine, cytosine, and guanine, and those are what's naturally supposed to be there in DNA. So they will make the right bonds, and as DNA polymers is making DNA, it will make DNA. Now, when you have a compound that looks like guanine, you essentially the polymerase will incorporate acyclovir into the chain, but because this looks different, it's not going to be able to make the appropriate bonds that's required for the DNA. And essentially what happens is that the process of DNA synthesis will be terminated. So that's how these agents will interrupt DNA synthesis. Now, one thing that's important to consider is that before they can actually be incorporated into the DNA, they actually need to be converted to the active form. So they do depend on the thymidine kinase enzyme that comes with the virus. So herpes virus has this enzyme. So essentially acyclovir needs to be phosphorylated by this enzyme, and that's how you get so normally nucleoside will be phosphorylated into monophosphate, and it will continue until the final step where it is incorporated into DNA. So the same is true. So acyclovir and famciclovir and valacyclovir will need to be phosphorylated, and that's something that could happen. So if there are mutations in this enzyme, acyclovir will not work. But pretty much for herpes viruses, resistant to acyclovir has been pretty rare. And just to show you the life cycle of herpes viruses, these are DNA viruses. So once they attach to the target epithelium cell, they will go inside, and then because they're DNA viruses, they actually need to go inside the nucleus in order to replicate. So they will have to go inside, and then they will replicate inside the nucleus, and then it will come outside and will have its other protein products, and will assemble into a virion, and then will release and infect the next cell. Now, some of the antibiotics used for management of bacterial and STIs include aminoglycosides, which we know bind to the 30S subunits of ribosome, and they inhibit protein synthesis. Of course, aminoglycosides associated with nephrotoxicity and ototoxicity. We'll also use tetracycline. Specifically, doxycycline has a big role for some of these infections, which We know they bind to 30S subunits similar to aminoglycosides to inhibit protein synthesis. For tetracyclines, they can cause photosensitivity. And deposition in bone and teeth, there's a question mark here because that was seen with the tetracycline itself, but some of the other agents in this class don't necessarily cause this. So doxycycline is, that's not really a concern with doxycycline. Macrolide, specifically azithromycin, has been used for some of the STIs. So the macrolides are bind to 50S subunit and they inhibit protein synthesis. And of course, with macrolides, QTC prolongation is a concern. The same with fluoroquinolones, QTC prolongation is a concern, along with a bunch of other things, among which is tendinitis, neurotoxicity, and not to forget about all the black box warnings for fluoroquinolones. And fluoroquinolones work differently in that they bind to topoisomerase 2, which is DNA gyrase, and essentially prevent replication of DNA. And last but not least, we have beta-lactams. So penicillins, especially for syphilis, penicillin has a big role. And of course, for for example, cephalosporins are also used for some of these. So ceftriaxone, cefixime. So these are essentially, the mechanism of action is the same. They bind to penicillin binding proteins. Now there are different types of penicillin binding proteins. So depending on which one beta-lactams bind to, that's how you get different spectrum of activity for different beta-lactams. And in general, they are pretty well tolerated. You do get GI upset and essentially hypersensitivity or rash. And in high doses, you can get seizure, and also drug fever is a concern in general, but very rare. Now, here are the three common things to, when it comes to penicillin, it's important to distinguish between different formulation. So there is penicillin G benzathine, which is brand name Bicillin, which sometimes there is a shortage of this drug. That's used IM, so intramuscular. Now, one thing that's specific about these IM injections, with this one in particular, is that it actually has a formulation where the repository provides tissue depots from which the drug is absorbed over days. So even though you gave a single shot of this in the muscle, it actually will be working over several days, which means that you get a little bit of the drug released every day. Now, it's important to note that this is for IM use only, and it is not for intravenous injection. There is a black box warning that says do not inject intravenously or admix with other IV solutions. There have been reports of inadvertent IV administration of this formulation, which has resulted in cardiorespiratory arrest and death. Another one that's similar to this is the procaine penicillin G. This one was actually discontinued in 2023. So technically we don't have to deal with this anymore, but this was similar to that. So it's a repository that provides tissue depots, and it releases over hours. Now, this one, doesn't last as much as Bicillin, and it doesn't have the black box warning, but essentially this one is also for IM use only. But then again, it's been discontinued, so we don't have that problem. Now, I'm showing you these three because when it comes to neurosyphilis, and that's specifically syphilis infection that has made it to the CNS, because these are, the IM injections are not going to work because you get a little bit of the drug released over time, which means that you're not going to get enough concentrations in the CSF. So these are not appropriate for neurosyphilis. So what you want is intravenous injection of penicillin so that you can get high concentrations into the CNS. And because this one, aqueous crystalline penicillin G, is short acting, So you can give a higher doses, so that's something to consider when we look at treatment. Anytime you have IV, you have to make sure that you don't do the other formulations. We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for the treatment of genital herpes, gonorrhea, chlamydia, and syphilis. Now let's explain the pathophysiology and clinical presentation of genital herpes, gonorrhea, chlamydia, and syphilis. Let's take a look at herpes simplex virus. Now, when the virus enters the body through the skin or mucous membrane, and that could be genital area, or it could be essentially anywhere where you have a mucous membrane. So you can think of the oral cavity. Once the virus enters, it will essentially go into the nervous system, and then it will have initially some symptoms that will be essentially on the skin. But once it goes to the nerve, it will have a period of latency. So it could be many years that the virus will be inactive, and then it will never really leave the body. So there will be episodes of recurrence. So every time there is a reactivation of this latent virus, there are two possibilities. One possibility, which we call recurrence, is that you will have symptomatic manifestations. So there will be, for example, blisters on the skin, and this will be a contagious phase of the infection, because there will be new viruses replicating inside the lesion, and this can be transmitted to other people by touch. And the other possibility is asymptomatic viral shedding, and this is essentially once the virus is reactivated, it goes to the surface of the skin. It's asymptomatic in the sense that it will not cause symptomatic manifestation, so there will not necessarily be a lesion on the skin, but because the virus is actively replicating, it will be able to shed new viruses, and this is also contagious. And this causes a problem because, well, it's easy to avoid transmission when there is an active lesion going on. People are, unaware of asymptomatic viral shedding, which is that they could, there's not much they can do to prevent this transmission when they have asymptomatic viral shedding. Now, of course, the virus can infect the orofacial area, so anywhere around the mouth and inside the mouth. And this orofacial herpes is more common with HSV1. So between HSV and 2, more likely to have HSV1 cause this type of infection. And again, regardless of whether it's HSV1 or 2, the course is essentially the same. There will be a period of latency followed by sporadic reactivations. Now, it can also lead to genital HSV infection, and this could be both men and women. And when it comes to genital HSV, it is more common to have recurrences with HSV2. But again, either HSV1 or 2 can cause genital herpes. It's just that it's more likely to have recurrences with HSV2. HSV1 just doesn't recur that often in the genital area. Now, another thing to note about this virus is that although someone may have genital HSV infection, it may not necessarily be limited to that region. So even if the route of transmission was sexual transmission, extragenital lesions may occur during the course of primary genital infection. So extra means outside of genital lesions. Now, another possibility is eye infections, so ocular infections with HSV. They're not as common, but they can occur, and they can be pretty much serious. And lastly, encephalitis can occur from HSV. So this is essentially infection in the CNS system, and that's something that also can happen with HSV. Now let's take a look at some of the manifestations of genital HSV infection specifically. So one thing to note is that the incubation period is about 1 week, so 4 to 7 days. So essentially once somebody is exposed, it will take about a week for symptoms to develop. And for the initial infection is essentially lesions that appear at the site of transmission, so typically the genitals or the adjacent skin. For the initial infection, it's usually the lesions are bilateral, so there is some symmetry, and essentially the lesions progress from erythema to papules to vesicles to ulcers that ultimately develop a crust. And without treatment, this essentially resolves over 2 to 3 weeks. And half of the patients report other systemic symptoms, so such as headache, fever, malaise, dysuria, or lymphadenopathy. After a period of latency, there will be recurrent genital disease, so essentially reactivation, which result either in symptomatic or asymptomatic viral shedding. Symptomatic recurrence may be preceded by localized prodromal symptoms. So sometimes people can tell if a recurrence is coming up. They can sense itching or tingling. So prodromal, essentially, if you look at this picture over here, the first phase of the infection is incubation period. Then the second phase is prodromal period. That's before the symptoms actually become visible. So prodromal is that just before the symptoms come up, and that's significant because if somebody anticipates that symptoms are coming up, they may choose to proactively start treatment and at the same time prevent transmission by practicing caution. As I mentioned, recurrence is less frequent with HSV1 compared to HSV2. So keep that in mind when we decide, when we decide treatment for these. And, they typically, the recurrences resolve within 5 to 10 days. Now, chlamydia and gonorrhea manifestations are pretty similar. So for chlamydia, it could be asymptomatic infection among both men and women. And in general, you can think of, urogenital as site of infection. So this will be pain or burning during urination, discharge from the vagina or penis, and pain or swelling in the testes. The second, and these are, depending on the route of sexual intercourse is where you would get these different manifestations. So for the rectal and anal, you will have rectal bleeding or anal discharge, painful bowel movement. And then outside of your genital and rectal, you can have conjunctivitis. And in severe cases, you can have joint pain and swollen lymph nodes. Now, when we look at gonorrhea, again, asymptomatic infection is common among women until complications occur. For men are more likely to be symptomatic, so it doesn't list men here. Gonorrhea very symptomatic in men, and again the same routes, right? So urogenital, again similar, symptoms for each route. So rectal and anal, and then one thing that's a little different between gonorrhea and chlamydia is that chlamydia, when for example, if you consider the oral route of transmission, chlamydia is less likely to cause sore throat, whereas gonorrhea is more likely to cause sore throat. So sore throat is pharyngitis, I should say, is more of a possibility for gonorrhea. And then of course conjunctivitis, and gonorrhea can be pretty severe when it gets to disseminated gonococcal infection. And then lastly, we will go over syphilis, so manifestation of syphilis. So it's important to think of syphilis at different phases. So we have primary syphilis, secondary, and tertiary. Primary syphilis essentially is, when someone is has just been exposed, and typically 3 weeks later they're gonna have the very first symptom, which is at the site of transmission. So typically a single ulcer or sometimes it might be multiple lesions, typically on the genitals area. That essentially marks primary syphilis. Now, sometimes these are missed because although there will be lesions, these are painless. So if somebody doesn't notice it because there is no pain, it's possible for them to miss this. Now, when we get to, assuming this is not treated, this will resolve on its own, but the infection doesn't go away. So these ulcers will go away, they will heal. And, about 6 to 8 weeks later, there will be secondary syphilis. So this is essentially a little more severe. So there will be, because the bacteria will grow everywhere in the body. So some of the manifestations that come up next include fever, headache, and rash. Especially when you see specific circular rash, small rashes on the flank, shoulders, arm, chest, or back. And typically on the palms of the hands or soles of the feet. And then after the secondary syphilis is resolved, assuming again no treatment, then the infection goes into a latent phase. And this is, pretty, it can be pretty long in some patients. So anywhere between, a few years to many years. And the latent, so typically we say the early latent is within the first year, and then late latent is anything more than a year. And after the latency is over, at some point it will develop into tertiary syphilis, and this is where you get the very severe complications. So typically involving the heart, so it can cause cardiovascular disease, but also neurologic conditions. And neurosyphilis specifically, which typically occurs as tertiary syphilis, it can really happen at any time. So even someone who has primary syphilis, it's not as common, but someone with primary syphilis can develop neurosyphilis pretty quickly. And neurosyphilis can damage the brain, so this is something that needs to be treated seriously. And here's a picture that essentially shows you what I described. So once somebody has infection, they will develop primary syphilis, and that takes about 2 to 6 weeks to develop after infection. So those are the local symptoms. Now, at any time, this can make its way into the CNS and cause syphilis. Neurosyphilis. With primary, typically it goes to secondary. For some patients, this actually may go to latency instead of developing those rash. So not everybody will have this secondary syphilis infection. So for that reason, it's easy for people to miss, because the primary syphilis, these lesions are painless, so people may miss it. And then if it goes straight to early latent, later on, it will go unnoticed to develop tertiary syphilis, which is, severe complications. And that's one of the reasons that the rates of syphilis are increasing significantly in recent time. We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for the treatment of STIs, and explained the pathophysiology and clinical presentation of some of these STIs. Now let's interpret diagnostic laboratory findings to confirm the presence of genital herpes, gonorrhea, chlamydia, or syphilis in a patient. Let's take a look at diagnosis of genital herpes simplex virus infection. Now, if the genital lesions are present, clinical diagnosis should be confirmed by a type-specific virologic testing from the lesion, and that's typically with a nucleic acid amplification test, and that has a pretty good sensitivity of that approaches almost 100%, so 91 to 100%. Whereas if you were to culture this, sensitivity of viral culture is low. And then there is a type-specific serologic test. So serology is actually from the blood, whereas that nucleic amplification test was done on the specimen directly from the lesion. which means there is no lesion. You can't really do this test because you need to have a specimen. Whereas serology can be done at any time, whether there is lesion or not. So essentially, you want to see if someone has, latent HSV, and the serology test that's type specific. It can distinguish between HSV1 and HSV2. So it essentially detects different glycoproteins from each of these, and it has a good sensitivity, 80 to 98%. But it has a poor specificity. So when there is a positive test, you have to make sure that it's not a false positive, so it needs to be confirmed with a second method. Now, these say type specific because there are some tests out there that are type common antibody tests. They just tell you if somebody has HSV infection. It doesn't distinguish between HSV1 and 2. So the CDC guidelines from 2021 do recommend to use type specific, so you can distinguish between HSV1 and 2. And that's implications for treatment, because we know that if it's HSV1, it's less likely to have recurrences, whereas HSV2 is more likely to have recurrences. So that essentially determines our treatment strategy, which we'll cover shortly. Now, when it comes to screening, these are the US PSTF recommendation. So they recommend against routine screening by blood test, so essentially the serology test, for genital herpes infection in asymptomatic people, including pregnant individuals. So it's not recommended. It's only when people have symptoms that then you essentially do the NAT and diagnose them with genital herpes. Now, when people do have genital herpes, those ulcers actually increase the risk of HIV transmission. So for that reason, all persons with genital herpes should be tested for HIV. Now, diagnoses of chlamydia and gonorrhea are pretty similar. So essentially, you use nucleic acid amplification test from the specimen, and the specimen is essentially the site of infection. So for women, if it is a urogenital infection, so vaginal or cervical swabs, or you can use a first void urine test to detect either chlamydia or gonorrhea. And typically these are tested at the same time. So because the manifestations are pretty similar, when you suspect one, you test for both of these. So that makes it more straightforward. For men, urethral infection can be diagnosed again using first void urine or a urethral swab. And I will tell you that most routinely people just get the urine sample for these. If you suspect the route of transmission was rectal or oropharyngeal, those sites can also be swabbed, because a urine sample might test negative where somebody may have oropharyngeal infection. So all three sites may be needed to be tested in certain individuals with risk factors. And something that's specific for chlamydia and gonorrhea is that patient-collected specimens are equivalent in sensitivity and specificity to those collected by a clinician using NAT. So it doesn't matter if the patient swabbing, for example, doing a rectal swab on their own, or the physician doing it. So technique is not really as important, or at least the studies have not shown much difference. Now, while we're doing diagnosis of chlamydia and gonorrhea, because of the common risk factors, these people should also be tested for HIV and syphilis. Now, when it comes to diagnosis of syphilis, it really depends on just, it relies on serology. So because this is not something that will have, specific specimen, because for the most part, there will not be a specific size. So primary syphilis, you can have some lesions, but outside of that, you're not going to have specific specimen. So diagnostic relies on serology, so you need blood samples. And so, in the case of neurosyphilis, you may also need a lumbar puncture to get CSF sample. But outside of neurosyphilis, essentially you're relying on serology. And we divide these into two groups. So we call some of them non-treponemal tests, and the other group is treponemal tests. And the difference is that non-treponemal tests measure antibodies in response to lipoidal materials, whereas the treponemal tests are antibodies directed specifically against the organism itself. And so there are pros and cons of each group, but the commonly available products essentially in the US is the RPR test for non-treponemal test. And that's rapid plasma reagent, and that essentially a blood test. And there are other options that I personally have not seen used, but for CSF specifically to see if someone has neurosyphilis, there is the VDRL test. So you need a CSF sample to do this test, and that's essentially stands for Venereal Disease Research Laboratory test. And then for the treponemal tests, you have different options. That the one that I have seen commonly used in the US is the TPPA, so the T pallidum passive particle agglutination. And how do we use this, right? So essentially, one thing to keep in mind is what happens with this serology. So here on the x-axis we're looking at time, and the y-axis we're looking at patients who test positive, what percentage test positive. I can see that essentially after 4 weeks of treatment, so sometime between 4 weeks and 6 months is when non-treponemal tests becomes detectable, so RPR for example, as well as treponemal antibodies, so TPPA. Now, with TPPA, because it's directed at the organism, these antibodies will last forever, right? So even if someone had an infection in the past and it's been successfully treated, these are gonna test positive over time, regardless of whether they have an active infection or not. Whereas non-treponemal antibodies, once the organism is cleared, the levels actually go down. So if it's treated and sero-reverted, meaning that antibodies will go away, so over time it goes down. And even if you don't treat it, over time, these levels go a little lower, but still be detectable. So that's something to keep in mind to see what happens over the course of infection, and specifically what happens with treatment versus no treatment. And there are two different algorithms for diagnosis. The traditional way is that you essentially start with one of the non-treponemal tests. So in the plasma, it would be RPR. And if it's negative, you do not treat. And if it's positive, you do a confirmatory test. So then you use a second test to confirm it. So if you use the non-treponemal test, then you confirm with the treponemal test. And then if it's positive, you confirm that it is a true positive and you treat. But then if it's negative, then you assume that this was a false positive, so you do not need to treat. Okay. Now, this is something that traditionally was used. The problem is these tests are not perfect. So when your RPR is negative, there's a chance that this actually might be a false negative and you may miss some people. So then there was the reverse algorithm where you do the opposite. So instead of starting with non-treponemal test, you start with your treponemal test. And if it's negative, you do not treat. Whereas if it's positive, then you get confirmation with your non-treponemal test and then you treat. So both of these algorithms are out there, and they have strengths and limitations. So and that's because these tests are not perfect. We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for treatment of STIs and explained the pathophysiology and clinical presentation of STIs, and also interpreted diagnostic laboratory findings to confirm the presence of some sexually transmitted infections. Now, given a patient case, recommend guideline-concordant treatment for genital herpes, gonorrhea, chlamydia, and syphilis. Let's take a look at the management of genital herpes. The goal of treatment for genital herpes is to treat or prevent symptomatic genital herpes recurrences and improve quality of life and suppress the virus to prevent transmission to sexual partners. Now, antiviral drugs neither eradicate latent virus nor affect the risk, frequency, or severity of recurrences after drug is discontinued. It just helps us manage the symptoms as well as reduce the transmission. Topical therapy with antiviral drugs have minimal efficacy, and therefore they are discouraged for genital herpes specifically. Now, all patients with first episodes of genital herpes should receive antiviral therapy regardless of severity, and these are systemic antivirals, so either oral or IV. And IV specifically should be provided, and that's IV acyclovir for a severe HSV disease or complications that necessitate hospitalization. For example, people with disseminated infection, pneumonitis, or hepatitis, or if someone has CNS complications such as meningitis or encephalitis due to HSV. Now, here are the treatment recommendations from the CDC guidelines from 2021 for treatment of first clinical episodes of genital herpes, and it doesn't matter if it's HSV1 or HSV2. So essentially any of the three oral antiviral regimens are recommended. So acyclovir for 7 to 10 days, valacyclovir for 7 to 10 days, or famciclovir for 7 to 10 days. Now you can see that acyclovir and famciclovir are dosed 3 times a day, so it makes sense to use valacyclovir, which is dosed twice a day, to improve adherence for patients, but any of these are appropriate for treatment. Now, the treatment is recommended for 7 to 10 days, but use clinical judgment, so if some patients may need more than 10 days if healing is incomplete. Now, treatment of recurrence is recommendation specifically for HSV2, because remember that HSV1 is less likely to have recurrence, and essentially there is insufficient evidence to make recommendations for HSV1 recurrence. But should you be in a situation where there is HSV1 recurrence, you can probably extrapolate from HSV2 recommendations. But for the most part, the recommendations are for HSV2 because that's where the evidence is. So when it comes to recurrence, there are 2 strategies. One is suppressive therapy, which you essentially continue to give antiviral agents to patients for long time. Or you can have episodic therapy. So episodic therapy, you essentially wait until they have a recurrence, and once the recurrence happens, immediately you trigger the episodic therapy. And we essentially use the same agent, so acyclovir, valacyclovir, and famciclovir for suppressive therapy specifically. So the dosing is a bit different. It's based on the doses that have been studied for this purpose. And you can see that valacyclovir has been studied as 1 gram once a day. So that probably makes it the easier option for patients who essentially have to take this for a very, very long time, if not lifetime. So, once a day. And episodic would be essentially once the patient has developed, you initiate these, and, acyclovir for 2 days is an option, or valacyclovir for 3 to 5 days, or famciclovir, 2 times, so 1 gram 2 times a day for a single day. That probably is the easiest one for episodic, to make it easier. But any of these agents are recommended for these purposes. Now, as far as the efficacy, essentially the suppressive therapy It's probably the most effective. It reduces frequency of genital herpes recurrences by 70 to 80% among patients who have frequent recurrences. Let's switch gear to management of chlamydia. So the preferred regimen for chlamydial infection is doxycycline, 100 milligram 2 times a day for 7 days. So this is a standard 7-day regimen. Alternatively, if someone cannot tolerate or access doxycycline, azithromycin 1 gram as a single dose or levofloxacin 500 milligram daily for 7 days are recommended from the CDC. Now with azithromycin, you might ask, if this is a single dose, why not use azithromycin as preferred? And that's because there has been increased microbiologic treatment failure, with azithromycin compared to doxycycline. So for that reason, doxycycline is more effective and is recommended first line over azithromycin. And that's including for rectal chlamydia and oropharyngeal chlamydia, doxycycline is more effective than azithromycin. Now, one thing with doxycycline, because it's dosed twice a day, there is a formulation available as delayed release. So it would be a single 200 milligram tablet, which requires once daily dosing for 7 days. It is more expensive, but it does have lower frequency of GI side effects and it improves adherence. So that's an option. Now, men and women who have been treated for chlamydia should be retested approximately 3 months after treatment, regardless of whether they believe their sex partners were treated. And that's to make sure that their infection has been eradicated. For gonorrhea, for the preferred regimen for uncomplicated gonococcal infection of cervix, urethra, rectum, or pharynx is essentially ceftriaxone 500 milligram intramuscular injection as a single dose. And if someone weighs more than 150 kilos, they would require 1 gram of ceftriaxone. So that's pretty much the standard of care right now. Now, if somebody for some reason cannot tolerate ceftriaxone, alternative regimen includes gentamicin plus azithromycin as a single dose. And if they needed an oral option, cefixime is an option, which is an oral cephalosporin that they can use as a single dose. Now, these alternative agents are not for pharyngeal gonorrhea. Essentially, these are not as effective for pharyngeal gonorrhea. So in that case, an ID specialist should be consulted to see what options are available, but the guidelines don't make any recommendation. Now, because people who have gonorrhea, the symptoms overlap with chlamydia. If chlamydia has not been excluded and somebody is taking either ceftriaxone monotherapy or cefixime monotherapy, because cephalosporins don't have activity against atypical agents, it is recommended to add doxycycline on top of the ceftriaxone to cover for potential chlamydia infection. And once the culture results are back and it's confirmed that the patient does not have chlamydia, this can be discontinued. Now, for gonococcal conjunctivitis, again, ceftriaxone is recommended, but at a higher dose of 1 gram. And any person with pharyngeal gonorrhea should return 7 to 14 days after initial treatment for a test of cure by using either a culture or nucleic acid amplification test. And all positive cultures for test of cure should undergo antimicrobial susceptibility testing because of the increased rate of resistance in gonorrhea. And men and women who have been treated for gonorrhea should be retested 3 months after treatment, similar to chlamydia, to make sure that their infection has been eradicated. Now, for syphilis, the treatment is the same for primary and secondary syphilis, and even for early latent syphilis. So early latent is someone who has been having latent syphilis for less than a year. So essentially, penicillin is drug of choice, specifically intramuscular injection. So it's a single dose because remember that this gives a large dose that's slowly released over a period of time. So that's pretty much the standard of care. For people with severe penicillin allergy, doxycycline, ceftriaxone, and azithromycin have been studied, but again, by far, penicillins have been studied the most. So even if someone has allergy, they may be able to get desensitized to penicillin and receive penicillin for that purpose. Now, for latent syphilis, so this is essentially latent for more than a year, or if the duration is unknown, and also for tertiary syphilis with normal CSF, so essentially tertiary syphilis but not neurosyphilis, so this excludes neurosyphilis. The preferred agent is again intramuscular penicillin, but not just a single dose. So this should be a 3-dose series at 1 week interval. So they get 1 dose today, the second dose 1 week from now, and the third dose 2 weeks from now. And alternative is doxycycline for 28 days. So the duration of treatment would be for 4 weeks instead of 2 weeks. For latent syphilis. For neurosyphilis, intramuscular penicillin is not appropriate because it will not lead to adequate concentrations in the CSF. So preferred is IV infusion of aqueous crystalline penicillin at large doses of 18 to 24 million units per day, and that can be done either as administration of 3 to 4 million units every 4 hours, or as a continuous infusion, and duration of therapy is 10 to 14 days. Now, alternative recommendation used to be procaine penicillin, but since this has been discontinued, we don't have to worry about this right now. We described the PK/PD properties of anti-infective agents used for STIs, explained the pathophysiology and clinical presentations of STIs, and interpreted diagnostic laboratory findings to confirm the presence of these infections. And we recommended guideline-concordant treatment for genital herpes, gonorrhea, chlamydia, or syphilis. Now, let's identify prevention strategies for genital herpes, gonorrhea, chlamydia, and syphilis in sexually active adults. Now, for genital herpes specifically, consistent and correct condom use has been shown to decrease but not eliminate the risk for HSV2 transmission from men to women. Now, condoms are less effective for preventing transmission from women to men. Now, for men specifically, medical male circumcision is associated with decreased risk for HSV2 acquisition among adult heterosexual men, and with decreased risk of HSV2 transmission from male to female partners, so it will benefit both. Now, currently there is no evidence that pre-exposure prophylaxis with anti-herpes antivirals such as acyclovir, valacyclovir, or famciclovir is effective for preventing HSV2. One thing that's interesting in men having sex with men and transgender women, daily HIV PrEP with Truvada decreases the risk for severe ulcers with symptomatic genital HSV2 infection, but not for HSV2 acquisition. So people who are taking HIV PrEP, they can still get HSV2. It's just that their ulcers will be less severe. Now, for chlamydia and gonorrhea, prevention strategies are similar, and the same can be said about syphilis. So essentially, sexually active individuals can decrease their risk of acquiring and transmitting these infections using latex condoms with all sexual activity, including oral, anal, and vaginal sex. So condoms should be used for any route of sexual intercourse, which limits the number, and also limiting the number of sexual partners can decrease the risk, and of course, avoiding anonymous sex. Now, persons treated for chlamydia should abstain from sexual intercourse for 7 days after single-dose therapy or until completion of a 7-day regimen and resolution of symptoms if present. And patients should also abstain from sexual intercourse until all of their sex partners have been treated. And the same is true for both chlamydia and gonorrhea. So, abstinence until treatment is complete and until all the sex partners have been treated. This concludes this presentation.